how we get to the diagnosis and just kind of overview of what each of these diseases they typically presenting with. Okay, so the overview, just a little bit about like what glomerulus look like and structure-wise, and then we kind of go through cases, you know, of a few patients. Primarily glomerular disease, primary glomerular disease, the scope is pretty much, you know, oh, thank you. Minimal change disease, FSGS, membranous, and all these like NPGN, IgA nephropathies often are kind of categorized, grouped into the primary glomerular disease. But we're not going to be able to go through like all of these diseases. Today, I'll try to cover minimal change, FSGS, membranous, NPGN, and IgA. Okay, so the one that's bold. And this is when we talk about primary, and you guys will see that there are going to be some overlapping, because as typically when we call anything or any disease like primary, we just, these are diseases just like happen. We didn't really like know so much, but some of these GN disease can be secondary too. So there's always some overlapping. And but primarily when we talk about primary GN, it's you know, grouping it in this way, it doesn't help like with the clinical management. It's just like the traditional way of trying to separate out like with different kind of glomerular diseases. So the presentation of someone with glomerular disease, how can they, you know, like what do they present with? Some could come in as a nephrotic syndrome. These are the patients who would have a hematuria, maybe hypertensive, and pretty much like kind of like active inflammation going on. Some can present with nephrotic syndrome, which, like you guys know, like syndrome, swollen, nephrotic range proteinuria, hypoalbuminemia, hypercholesterolemia. Or they can also come in the form of RPGN, which kind of, you know, we usually joke that it always come like Friday afternoon when someone come in with the RPGN. Or they can come in as a chronic kidney disease, just like being referred, or they can come to it could be one of your clinic patients that you find to have some hematuria and proteinuria and ended up having a glomerular disease. Or like again, you know, or they can just like come in and say, oh, but my I have like bloody urine, or like pink urine, or having frothy urine. They can present with just isolated proteinuria or hematuria as well. So again, you know, primary glomerular disease, typically what we meant by that is mainly involve the kidney and glomerulus, but not other organs, and it's not secondary to other systemic illness. But there is, again, you know, overlapping that some of the disease can, or medication or certain conditions can cause glomerular disease that we categorize in the primary glomerular disease as well. So this is a normal glomerulus. So you can see here the drawing here correlates with what we see on the pathology, that it's, so this is the, you know, Bowman space, right? And you have the endothelial. So this is a capillary lumen. And then there's a podocyte, which is yellow here. And we usually don't really see the kind of, you know, podocyte structure on the light microscopy. But then you have the arterioles that, depending on the cut, so we don't always see that, you know, on particular cut. But normal glomeruli would have 1 or 2 cells per capillary tuft, and the lumens of the capillaries, like here. Wait, you can't see my, now you can see my arrow, right? I've been pointing on, on my presenter view. So this is a capillary lumen that are open, and the capillary wall thickness, if you like try to, you know, remember these pictures, it's kind of this pink line. This is the basement membrane. This is normal thickness, so they look thin and crisp, and no evidence of mesangial expansion. So mesangials are something, you know, like right in the middle here, right? So the pink area here is a normal mesangial that looks like. If there is mesangial expansion, you would see more of this like pink structures, kind of, and then maybe more cells in the middle of the tufts here. So glomerular capillary walls, again, you know, we from the inside go out to the outside. So you have the endothelium that's usually, so the endothelium is fenestrated. So there's pores, you know, there's holes. And normally it's covered with a negative charge. So that's why, you know, the albumin typically does not leak out, because negative charge and negative charge. So it doesn't, you know, leak out into the urinary space. And then there you have the basement membrane that are comprised with the matrix proteins, and it's a kind of continuous between each capillaries. So you see like all this basement membrane here. Oh, right here, that's line. And then on the outside, right, so we're going inside to the outside, you have epithelial cells, which in the kidneys we call the podocytes. So the outer layers of the capillary wall, and there's the food processes that can be, if there's something wrong with the food processes, then you often would, you know, would have proteinuria, for example. So these food processes are connected by the slit diaphragms, and so these are some of these are the target that if you have a mutation in the process of making some of this protein, then you can have glomerular disease as well. And then so this is kind of, you know, what we the structure in the glomeruli looks like, and you know, each kidney you have about 1 million of this. 1 million of glomeruli for each kidney. Two like hallmarks of a glomerular disease is like you would not suspect someone having glomerular disease without having proteinuria or hematuria. And some can just have proteinuria, and some just have hematuria, and some have both proteinuria and hematuria. So basically, like I said, you know, normal capillary basement membrane or the walls here would not let the red blood cell or let any protein out. But if there's some ultra permeability, then sometimes it can lead to protein. If there's a rupture of the capillary walls, then you see there's a hematuria, so the red blood cell can leak out. So some of the examples of the mechanism that can lead to proteinuria, for example, in FSGS, or minimal change, there could be some cytokine release that causing the epithelial cell injury, and that can lead to proteinuria. Or if there is some immune complex that deposit in the basement membrane, then you can have you know, increase the thickening of the basement membrane, and that can lead to proteinuria as well. Or if there is the deposition of the abnormal proteins, for example, like amyloidosis, so that can also lead to abnormalities of the basement membrane and lead to proteinuria. So all of these are the diseases that cause nephrotic range proteinuria, more or less. So again, in the nephrotic syndrome, a clinical manifestation, you know, I like this, you know, if anyone like, you know, read the book or look at the atlas from Frank Netter, you know, it's pretty illustrative. So these are, you know, the patients that come with the typical nephrotic syndrome. In pediatric, probably would like see like a lot more for certain diseases. more than 3 or 3.5 gram of proteinuria. And you guys know that nowadays we can do a protein creatinine ratio, just a spot urine sample. You don't necessarily have to do a 24-hour urine collection, which in itself can be challenging sometimes, and depending on how the patient collect them. So the spot urine sample for protein creatinine ratio is a pretty good test, just to like screen or figure out if someone is nephrotic. These patients typically are edematous. You can see here the pre-sacral or the lower extremity edema. It can be from either this patient is losing so much protein, they have a low oncotic pressure, or sodium retention due to the RAS activation. And majority of these patients are hypertensive, they have hyperlipidemia, and certain diseases are more prone to have hypercoagulable state. Okay. So hematuria, pretty kind of, self-explanatory. The patient sometimes can come in with gross hematuria, or they can just they may not know about it, but they actually have microscopic hematuria. So the definition of the microscopic hematuria is that there is more than 5 RBCs per high power field. And when we typically talk about patients with hematuria, they can be asymptomatic, right? And sometimes they may see gross hematuria. 5 to 10% of the general population can have microscopic hematuria without having particularly, a kidney disease diagnosed. But, glomerular disease is not the most common reason for hematuria. So I don't want you guys to go out after today. It's like anyone with hematuria would have glomerular disease. So it's still less than 10% actually represent glomerular causes. But you should have suspicion, especially if there's proteinuria in combination with hematuria. So nephritic syndrome, typically hematuria is kind of, we expect to see hematuria in certain disease mechanisms that cause nephritic syndrome. And it can be from other GN as well, post-infectious, can have immune complex deposit, and that can disrupt the basement membrane, and you have hematuria, the red blood cell leak out. So I'm gonna keep going. So this is what you could see if you do a spun urine exam. Someone had the glomerular hematuria. So you can see the RBC cast, and these pictures represent. So the RBCs are the smaller size, right? So you would see per width of the cast, there are a more number of cells as compared to if you have the white blood cell cast or a tubular cells cast, you won't have as many cells. But this is pretty, this is a good picture that shows this is RBCs, and they just, this is forming the cast. So this is if you see this is definitely glomerular disease. Or you can see the RBC, and this is from the phase contrast microscopy that we now have. So if you go down, if any one of you had gone down to the lab, the main lab on the first floor, they used to have a pretty crappy microscope, but now it's pretty fancy, and you can do even drop field. I used it a couple weeks ago. This is a phase contrast, which is make it easier to spot dysmorphic RBCs that look like Mickey Mouse, right? So this is what we call Mickey Mouse ear. So this represents dysmorphic RBC. So you definitely have, this is glomerular hematuria. So if you have hematuria from having stone or, a bladder cancer or some bleeding along the urinary tract, you would not have dysmorphic RBC. So this is the result of the RBCs kind of squeezing past the glomerular basement membrane. Okay. So this probably, you know, if any slide that you guys remember, I would very much like for you guys to have a photographic memory of this. It would be really helpful. I mean, I like by myself that, you know, if I could remember this like one slide like early on, like during the training, it would be like helpful. By now, I've been doing this for a while, so I kind of like know already. So this is a spectrum, and like I said, they can come by. The patient can come in nephrotic, which have more like proteinuria, 10 grams proteinuria, 5 grams proteinuria. So these are diseases that we commonly would think about if the patients come in with proteinuria predominantly, other than hematuria. They may not even have hematuria. You would think about minimal change disease, FSGS, membranous. If the patient comes in with more like heavily hematuria and some proteinuria, but you know, not as bad, not massive, you might think about anti-GBM, small vessel vasculitis. I kept pointing in the wrong slide. Okay, so post-streptal GN, or if they come in with the mix of proteinuria and hematuria, you could think about certain things like, you know, diabetes, amyloidosis, MPGN, or lupus can come in with like any, you know, any point of the spectrum. It can be proteinuria, or it could be just hematuria or combination. Or IgA nephropathy normally would have hematuria and some proteinuria, but not as massive as minimal change FSGS or membranous. So, okay. So this first patient is a 19-year-old female with lower extremity edema for several weeks. Thyroid function and the chemistry are pretty normal, and the dipstick showed that she had full plus proteinuria, but no hematuria. Serology so far are negative for ANA, hepatitis or HIV, and eventually they had a kidney biopsy shown down here. This is the electron microscopy, which just to kind of help orientate yourself, this is the RBC. So this is the endothelial side. This is the basement membrane. And this is where the podocytes are supposed to be. You guys can shout out, you know, if anyone wants to try this. Minimal change disease, FSGS, normal glomeruli, and MPGN, or like you really don't know. With the essence of time, it's just gonna keep, you can write down the questions for yourself, and then, you know, afterwards you can come back to see if you can get this answer correctly. So this patient has a minimal change disease. Epidemiology, typically, you know, most frequently present it's most frequent nephrotic syndrome in children. I don't know why the picture is like this. In adults, this is bimodal. So the adult, the peak incidence is older. So it's 65. So it's a disease that we see quite commonly in nephrotic syndrome in children or older patients. And the main pathology is the food process effacement. So this is normal. You can see that this is what the food process is supposed to look like, but this is in minimal change disease, you can see just effacement of the food process there. So on light microscopy, sometimes it just look normal, or that's hence the name minimal change disease. So on light microscopy, because that's where we look first. On light, it just looked like there's nothing much going on. So that's why we call them minimal change. But on the EMs, which often we wait until the EM to really confirm that this is minimal change disease. Pathogenesis, unclear. Like again, you know, this is like we categorize this into primary GN. but there's some evidence that it could involve the T and B cell dysfunction. Some experiment by infusing the circulating glomerular permeable factor that can actually cause the minimal change disease. So some of the mechanisms is immune related, and that is why we tend to use immunosuppression in the treatment. So again, idiopathic in most cases, but this is where the secondary comes by, and then you can question that, oh, is this primary GN or secondary GN? But some of these can cause minimal change disease, medications, malignancy, infection, allergic reaction, or some autoimmune process. But the medications, like any nephrologist would do, is like we bold NSAIDs because it can cause a lot of problems. So NSAIDs can definitely cause minimal change disease, among other troubles that it may. Some of these medications that a lot of times it's a treatment for rheumatoid arthritis. Now with the newer agents may not be like very much so, but some of these medications that had been described as a cause of the minimal change disease before, pamidronate, which we don't seem to use much anymore anyway right now, or some interferon. Malignancy, particularly hematologic malignancy, more commonly can lead to a minimal change disease, and hepatitis, infection, HIV, syphilis, these can also cause minimal change disease. Okay, so typically they come in with edema, hypertension. Rarely you would see azotemia, so the creatinine could be normal, but the proteinuria is very high. So we call this like massive proteinuria. Someone come in with like 20 grams, and it's not the and this is like pretty. It's not the lab error. So if you see like 10, 20 grams of protein or protein creatinine ratio of 20, this is how the minimal change disease commonly present with. So how do we treat them? Because a lot of these patients have fluid retention, edema. So in addition to diuretics, we must not forget that they have to restrict the sodium, salt intake. Otherwise, it's going to be like very difficult to manage their edema. And we would try to get them on a RAS blockade, either ACE, ARB, or mineralocorticoid antagonist. And the first line of treatment for minimal change disease, like I said, since there's seem to be some immune process going on, we just use a steroid. In children, there's a much more responsive to the steroid. 90% achieve complete remission, and often in kids, we don't, unless they don't respond within 8 weeks, kids normally don't get the kidney biopsy, because like in kids, this is like for some of you guys like med peds, if you see this nephrotic syndrome in kids, like normally we would just try the steroid. If by 8 weeks there's no response, then they may need the kidney biopsy. Adults, there's a lower rate of patients that achieve a complete remission. And the hallmark of the minimal change disease is that the relapse is common. So there are times the patients might have a complete remission and even kind of discharged from the clinic because it's fine, and then something trigger and they come back in with the same picture. Some of my patients actually do the urine dipstick at home and trying to monitor this too. Which is helpful. Some of them kind of feel when they're about to have the relapse or it definitely, if they started seeing the urine getting frothy, that's kind of a pretty evident that they have the relapse. The second line agents are other immune modulating agents, immunosuppressions that we have tried to use to spare some of the steroid, because the more relapse that they have, the more steroid that they're going to have exposure to. So next one, so I mean, it's not the case, but FSGS can be caused by any of these. So loss of renal mass, for example, patient had nephrectomy, or can HIV cause FSGS, midodrine, hypertension, interferon, or all of the above. This is the part where I think like doing in person would be helpful, because you guys can just like shout out. But now everybody's mute, so, and I'm not monitoring the chat box. Okay. So FSGS, as you can see here, is more or less like some of us have said that FSGS is kind of like not a real diagnosis, right? Because essentially it's kind of describe what the pathology finding is, and it is. So it just describes like focal and segmental. Focal means that not all the gloms are affected, and segmental is just only part of the glomeruli that show a pathology of the sclerosis. So hence this long name, FSGS, which I thought that I would never be able to remember this. Histological classifications. There are different patterns of the FSGS. You can have but essentially it's a collapse of the capillary loops. And there's a segmental hyalinosis and food process effacement. So the most severe form of the FSGS is what we call the collapsing FSGS, as you can see here. Like things that kind of like suck down into like the middle of, this is a silver stain. So you see like the black color stain the basement membrane, that it should be kind of like evenly distributed, right? But because it's like collapsing, you see it's just, or this one is showing the collapsing, that it's just kind of all crumbled into the center of the glomeruli. Tip lesion, this is what you see that only some part of the glomeruli are affected at the tip, and this is the one that has the best prognosis. And then there are other kinds of the FSGS that have been described, but the most severe one is the collapsing FSGS. So it actually can represent a number of patients on end stage of kidney disease. One of the leading causes of nephrotic syndrome in adults and children. So primary FSGS is, again, it's just like we don't really know like what's the cause. Secondary, it could be from hypofiltration or scarring from previous injury. It can be from medication or infection. So familial FSGS is if there are patients who present with like everybody in the family have had a kidney disease on dialysis. They may not know that it's FSGS, but if they have like a couple of generations with the kidney disease, you would think about familial FSGS. And now that we actually can identify some of the gene mutation, it's helpful in knowing how to manage this patient or even their prognosis afterwards. So the pathogenesis of FSGS is, we're talking about the primary FSGS, is there's diffuse injury of the podocyte and the epithelial cell layers. So you could see that and then eventually it caused some scarring. So this part, if you don't have all the surface of the glomerular basement membrane to do the filtration, that can affect how the GFR, right? So this is why they turn out to have a kidney reduced GFR and a proteinuria because of the structure of the basement membrane is defective. There's also the theory that there's a circulating factor that called SUPAR that may play a role in the regulation of the food processes. So if you have this circulating, it's thought that it could be one of the mechanisms why the development of FSGS. So secondary, it can be from either adaptive response to the nephron loss. Typically, if the patient had a nephrectomy and they just have hypofiltration that is kind of go unchecked, then that can lead to FSGS too. Podocyte injury is kind of pretty much like the hallmark. So anything that are toxic to podocytes can eventually lead to FSGS. Oh, okay. So familial FSGS, so you could see some of the gene mutations such as the nephrin or the podocin, which is part of the structure in the basement of the food process, can lead to FSGS. And in this case, if the patient had the kidney transplant, right, they have the new kidney without this mutation, the outcome of the transplant is excellent because then they don't tend to have recurrence. So it's very helpful if we have a suspected case of familial FSGS and we do genetic testing, you can be pretty certain about the prognosis after the kidney transplant, provided that the patient, does what it's supposed to do, taking all the immunosuppression and all that. So more genetics, as you may have, have heard over this past, I guess, 10 years or so that we talk about APOL1. So FSGS is the most frequent form of nephrotic syndrome in African Americans, and they have fourfold risk of FSGS compared to Caucasians. Significant family history with the ESRD. The patients with FSGS, the African American population have a family history of it. HIV-associated FSGS also is predominantly found in African American population. So, several of the studies in the past decade, focused on APOL1, that if you have two risk alleles, that increase the risk of having FSGS. Also, HIV-associated FSGS or HIVAN, which we actually had journal club, this morning in nephrology, and there was one of the questions Dr. Choi asked our fellows that if any of you guys seen HIVAN or HIV-associated nephropathy nowadays, and nobody said yes. So the reason is because, we have the treatment, the antiviral that is very effective nowadays. So, but again, it may be on your board exam still, I don't know, but it's the most common form of HIV-associated renal disease, maybe in the past, not currently. And typically, you would see collapsing FSGS if this is HIVAN. If you have patients who had never been treated for HIV and just come in pretty much with the nephrotic syndrome, you may see the HIVAN. Usually associated with the high viral load, and there's an increased risk of HIVAN in African American population with the APOL1 risk alleles. So FSGS, again, the hallmark that they come in with, they can come in with proteinuria, and doesn't necessarily have to be nephrotic, but at the later stage, most of them would be nephrotic, which is more than 3 grams per gram. They may have hematuria, doesn't necessarily need to have one, and hypertensive and edema. Typically, if it's a primary FSGS, meaning that it's not, not secondary to hypofiltration or drugs or infection, the symptoms are pretty abrupt and more severe. And again, there's some clues for familial FSGS, that if it's familial, if it's a genetic mutation affecting the food process structure, then treatment with steroid, for example, is not going to be effective, right? I mean, you can't use steroid to fix the abnormal structure in the basement membrane. So you can have a kind of, raise the suspicions that it may be familial form if the patient does not respond to the steroid. So treatment, again, salt restriction, diuretics, and the RAS blockade, immunosuppression have been used to treat FSGS, but it's not like, gold standard treatment. So we've tried steroid in some of the patients. Less than half will respond to the steroid. And the second line agents, someone would try immunosuppression with the calcium inhibitor or the CellCept, and then others with the plasmapheresis. This more so in the recurrence in the kidney transplant patients, or use rituximab, which we have been using. Rituximab has had use a lot more now these days for a number of rheumatologic and also the kidney disease as well. High rate of occurrence and magic number in medicine, 30% it can be as high as 30% in kidney transplant patient for FSGS to have a recurrence. And in some patients, this recur to the point where how many kidneys are enough, right? Because if they recur in the first kidney transplant, it's likely that they will recur in the second. So at some point, I've seen the case where it had kind of gone to the ethics, like, is it right? Is it ethical to keep transplanting the kidney with the recurrence FSGS? I think like most centers would probably stop after 3 kidneys or so. And then it can happen pretty fast, pretty much like the following day after the kidney transplant, if they were to have recurrence. So we monitor these patients pretty closely for proteinuria. It gets a little tricky if the patients get transplanted before they lose all the kidney function, because they would have the urine from their new kidney and then still have the urine from their own kidneys. So, but regardless, we monitor closely after the transplant. And because there's a theory about SUPAR, the circulating factor, plasmapheresis are often used in recurrent FSGS in kidney transplant patient. So, I mean, hopefully at some point, if we can define all these genetic testing in a lot of these patients, it might help with more with the treatment for the patients with FSGS. So let's move on to next patient. So 63-year-old with acute flank pain and have microscopic hematuria. He had nephrotic range proteinuria and hypoalbuminemia. So his serum albumin is less than 2, pretty severe. Ultrasound is pending. What do you think is most likely diagnosis? I'm going to keep going. This patient, so, the clue is like, kidney stones, they can have hematuria, but probably not proteinuria. MPGN with renal vein thrombosis is kind of tempting. Membranous nephropathy with renal vein thrombosis. This is the questions leading to the membranous. So this is the one with the answer. FSGS with the PE, kind of not quite explain the acute flank pain here, and polycystic kidney disease typically do not present with the severe proteinuria. So see, so membranous nephropathy, again, it can be primary where it just kind of happened, and idiopathic, as we are kind of naming it already, as primary membranous. Now, it can be associated with So secondary, right? So secondary membranous, it can be from some autoimmune disease, it can be from infection, malignancy, sometimes stem cell transplant with the graft versus host disease, and from drugs, again, you know, NSAIDs, gold, penicillamine, anti-TNF agents. So all these can cause membranous nephropathy. It's one of the most frequent causes of nephrotic syndrome in adults, and the old, I think teaching would say that in Caucasian, the membranous nephropathy's most common causes in African American is FSGS, if you have a true nephrotic syndrome. So pathology, there's an immune complex deposit in the subepithelial space, and the thickening of the basement membrane due to the extra matrix formation. And also we will see some food process effacement explaining proteinuria in these patients. So this is the pathology that, let me show you. So the light microscopy shows thickened capillary loops. And this is a normal glom, so you can see the difference, right? So this basement membrane is quite thick compared to the one here is pretty thin here. And this is the electron microscopy. Again, this is from the endothelial space. This is basement membrane, and the dark structures here, this is the immune complex. So you'd see here, here, and the food process effacement is supposed to be around here, but you're not seeing it because there's some effacement of the food process too. So the difference from minimal change, the minimal change disease, you would not see this immune complex, right? So if you see the immune complex in subepithelial, so it's more towards the epithelial side, this is the diagnostic for membranous nephropathy. Let's skip this. And now you also may have seen like the recent literatures about the phospholipase A2 receptor antibody that had been identified that as a pretty useful tool to diagnose towards primary membranous nephropathy, that whether this is just a marker or it's actually is pathologic, we're still kind of studying it, but we've been using it clinically when we suspect membranous nephropathy. You would see that, the nephrology, we would order for a PLA2R antibody, which is can have a pretty high positive predictive value that this is primary membranous, not secondary. So again, they come in with a pretty nephrotic range proteinuria. Majority of the cases, they commonly would have a microscopic hematuria, and membranous nephropathy. Typically, on board question, I mean, this is the type of the glomerular disease that are most prone to have hypercoagulable state, especially if the albumin is less than 2. So these patients, need to have some prophylaxis for DVT, or PE by putting them on anticoagulant of your choice, probably a NOAC nowadays. Again, 1/3 seems to work in a lot of things in medicine. So what happened to these patients? Progression over 10 years at 1/3 can go to spontaneous remission. You don't have to do anything, just let it be maybe ACE, ARB, and control their blood pressure. But 1/3 of them can have spontaneous remission. And 1/3 have a slow progression, and then 1/3 progress to end-stage kidney disease. So obviously, we kind of, need some clues to know which one we should be actively treating instead of waiting for them to have a spontaneous remission. So in male patients, if there is proteinuria more than 10 grams, if the patient is hypertensive, and also if there is significant fibrosis on the biopsy, this is like all this risk for progression. they're presenting creatinine also is part of this. Not sure why I didn't put it on here, but if they already have abnormal creatinine, that's also that might prompt you to treat it more aggressively instead of waiting for the spontaneous remission. So conservative therapy that we try to give everybody is to have RAS blockade, control the blood pressure, again, salt restriction, diuretics, and also work on their cholesterol as well. So we put these patients on statin therapy while waiting for the disease to go into remission. The treatment with the immunosuppression, we have to kind of do our diligence to just to make sure that, well, I guess you cannot say that to make sure, but as you know, secondary membranous can be from malignancy. So age-appropriate cancer screening should be done. Pretty much if the patient have a membranous nephropathy from malignancy, it should be pretty evident. You know, you shouldn't have to look like too much. You would see it either from, you know, have lung nodules or have like other type of malignant cancer that would have been detected by age-appropriate screening. So in other words, like we not recommend that we should put everybody on like through PET scan, you know, if they have a membranous nephropathy to rule out malignancy. Oftentimes, if 3 to 6 month trial of conservative therapy and does not lead to any improvement, you would want to start immunosuppression, especially if there's those risk factor for disease progression. The first line would be the use of the steroid with Cytoxan, and now rituximab also, I should probably update this slide, but rituximab has also been a non-inferiority to Cytoxan, and it's easier to use, it's more tolerable, so a lot of patients now can have rituximab in combination with the steroid, and or a trial of using calcineurin inhibitor. Okay, I think we might have a little more time. So 45-year-old female with hepatitis C, come in with new onset hypertension, purplish skin lesion on the legs and edema, 4+ proteinuria, 1+ hematuria, creatinine 1.5. So the biopsy show that there's subendothelial, so this is not subepithelial, right? And there's some mesangial deposits, double contour of the basement membrane. So this is a representation of MPGN. So again, this is the, I want to skip to pathology finding, which is kind of, you know, kind of nice to look at. This is what we call the tram tracking. The basement membranes are duplicate. As you can see here, the dark line here, this is, again, this is silver staining. So you see, it's, typically the basement membrane should be just one crisp, like thin line, but in this patient, it shows like a track, right? So this is a double contour. So this is a hallmark of MPGN, and most commonly associated with hepatitis C. Now that we also are treating hepatitis C, you guys are gonna probably see less and less of this MPGN in the hepatitis C or with the cryoglobulinemia. But so this used to be quite common with patients with Hep C. I'm gonna skip there and then just trying to go through. Typically they present with a combination of proteinuria and hematuria. It doesn't have to be nephrotic, hypertension, and sometimes they have a low C3, particularly if they have cryoglobulinemia. So again, you know, this is just showing the cryoprecipitate, and they may have a skin rash like this, which is, you know, appearing, we call it leukocytoclastic vasculitis. This is make us think of MPGN related to cryoglobulinemia. Treatment depends if there's a related to viral infection, we treat the underlying causes. In severe cases, sometimes we would consider using the steroid or rituximab or Cellcept. There another type of MPGN, which is called type 2 or dense deposit disease. There's no established treatment for that, and would very high rate of recurrence in the kidney transplant as well. I didn't include in this talk, but the complement associated glomerular disease would often present with, the pathology-wise, it would look like MPGN as well. So just know that there is, going to be like more of the classification might also change. Like someday we might not even call it MPGN type 1, type 2, type 3, because we're learning more of the mechanism of things that have gone wrong. So last case here, I think I want to just like mention about IgA nephropathy. So, young men have some proteinuria and some microscopic hematuria. Before this, some had some cold symptoms, but really no other complaints. And in the past, he remember having a gross hematuria, which just kind of went away by itself. This is like often, if this is like in the pediatric patient, they may come in with abdominal pain, they might have a little bit of skin rash, that would get the diagnosis of henoch-shoreline purpura, which has association with the IgA nephropathy, that the biopsy findings would be like essentially, showing the IgA nephropathy. Most common primary GN in the world, actually, and 25% of the IgA nephropathy patient had become end-stage kidney disease. Peak incidence is, in the younger patient. Then the literature say that most commonly occurs in Asians and Caucasians. In Asians, it might have been biased too, because there are a higher percentage of biopsy. So, in like Japan, particularly, like biopsy patients a lot, so they may see more of that. So it's a sporadic, but there is also the newly learned that IgA nephropathy could be a genetic disease, because there's the IgA molecules were abnormal, and that tend to be the familial. It's a galactosidase chain of the IgA that was abnormal. So there are groups that's studying the familial IgA nephropathy. So in light microscopy, you might only see mild mesangial proliferation, and then the final diagnosis is often made by the immunofluorescence, which is stained for IgA. And then on the EM, you might see the electron dense deposits in the mesangial space. So again, they can present with gross hematuria, microscopic hematuria with or without proteinuria or hypertension, and some of them might have abnormal creatinine. The treatment is, this is one of the glomerular disease that we actually don't have a specific treatment yet. So, there are a couple of things on the horizon that we might be able to use. But right now, conservative therapies, you want to put these patients on RAS blockade, and we have tried using the immunosuppression. It really depends. Not all of the patients respond to steroid, Cytoxan, or even, like rituximab, Cellcept. It has all been tried, but no particularly like a big landmark study about the treatment for the IgA yet. Fish oil had been shown to have some benefit, that most likely because the anti-inflammatory effect, but we're talking about like 12 grams of fish oil, which a lot. So, patients don't like to take that much fish oil, because, they can smell like the breath is horrible when you take that much fish oil, so a lot of them don't want to. The tonsillectomy is controversial. It may have been done in patients who repeatedly have URI, and that seems to precipitate the IgA nephropathy or the flare of the disease. So I think, I mean, that was, I want to just like spend a few minutes just showing you guys how the kidney biopsy is done, because, you know, before we got to all those diagnoses, the patient had to undergo the kidney biopsy, and I don't think that any of us had a chance to talk to you guys about the kidney biopsy. But what we tend to do most commonly is the ultrasound guided the biopsy. So you see that it's pretty like safe compared to 30, 40 years ago, where it's like we're doing this blind, and you might not know until you have a pathology result that it's actually liver, not the kidney. Usually it's easier to do the left kidney because the fact that the liver, the big organ, the liver, is not in a way. The patient is on the prone position or maybe on their side, and the biopsy is done with the ultrasound real time. Oh, what happened? Oh, okay. Right, so this is how it's normally done. We don't want to go through the kidney. We want just to get like this cortex. So the gloms are in the cortex. This is where we want. We don't want the medulla, and we certainly do not want to cut through the kidneys, and we do not want to get into the urinary space. And that's when the ultrasound is helpful. So this is what we see, that the core of the kidneys. When we do the needle biopsy, we try to go down and just to see, and this is from on the dissecting microscope, you can kind of see the glom here, like the red dots here. This is gloms, and this is when we say to our radiology colleagues that, okay, like we've got sample, because this is what we need to diagnose glomerular disease. We kind of need the glom. So we get about 2 or 3 of the cores, and we split the cores into light microscopy, immunofluorescence, and the EM. So this is pathology is kind of, you know, take charge of doing this. So sometimes you might see the report that say, oh, you know, they didn't have the glom for the EM, or they didn't have a glom for the IF, because, you know, if the cores are not does not have enough gloms, or if they split in the area where there's like no gloms, then you might end up not having the adequate tissue to do some staining. So it's, you know, we do the biopsy to establish diagnosis, to guide therapy, and sometimes also to decide whether we should just treat, because if the kidneys are all scarring, then it's not worth going for the aggressive therapy, and assess degree of the active and the chronic changes. Again, the indication for the biopsy, who do you want to biopsy? The patient with glomerular hematuria. Non-nephrotic proteinuria can also be an indication. It doesn't necessarily have to be a nephrotic syndrome. In the patient with acute nephritic syndrome, like the one we suspected anti-GBM or ANGA vasculitis. And my teaching is that before we stick a needle into somebody's kidney, you should have some kind of diagnosis in your head, and we do a biopsy to confirm that diagnosis with all the clues that you have, the blood tests, serologies, presentation, history. But sometimes we do have cases where they have acute renal failure, and we really just can't explain, and we do the biopsy to find out the answer. But generally, you should try to have some diagnosis in mind. It's actually, you know, kind of, not that I have fun on the patient's misery, but it's kind of like, it's fun to when you get it right, of what your differential diagnosis is. But contraindications, so like we're not, this is not like commonly seen, but you know, I have to list it on here when we get a consent from the patient. So contraindication is if you have small kidneys already, like fibrotic kidneys, or if one kidney, you might think twice or maybe more than twice before you stick a needle in there, because if bad things can happen. If there's a significant bleeding, then the patient would certainly, you know, might lose that kidney and then they end up on dialysis. If there is cysts, we don't typically biopsy because that's not how we manage the cysts. Definitely, if there's a tumor, we don't biopsy the kidney renal cell cancer, for example. We just, you know, try to take the suspicious cyst or tumor out without the biopsy, because the biopsy you can see through the track that you do the biopsy and can lead to metastasis. If the patient has a coagulopathy, then they can have a biopsy. We have one case right now that we can't biopsy because the platelets is 40,000, if any of you are on that service. If the blood pressure is uncontrolled, often you guys might experience that the IR would just not do the biopsy because the blood pressure is high. That increased the risk of bleeding. If the patient have hydronephrosis, that certainly, that might have been the cause for the kidney failure. And if there's infection, we do not want to biopsy either. Skin infection over the biopsy site, of course, you know, you cannot get through that and like bring the infection into the kidneys. Or if you have patient who cannot cooperate,